Okay, tumor progression. Once you've understood the idea of carcinogenesis and you understand that carcinogenesis is going to knock out key important regulatory elements, then the next notion is that as a tumor cell grows and begins to produce additional daughter cells, it will pick up additional mutations. And those additional mutations will allow for tumor progression. And so eventually what will happen in the case of cancer is that accumulation of mutations will result in invasion and spread. And remember that the hallmark of cancer, of malignant neoplasia, is that it locally invades, and the defining feature of malignant neoplasia or cancer is that it will spread to distant sites, which is also called metastasis. Now, in order for this spread to occur, there are a few characteristic changes that have to arise within the tumor to promote such spread. And so what I'd like to do is walk you through those. The first is downregulation of E-cadherin. Normally, when you look at epithelial cells, these are epithelial cells, you're well aware from histology that epithelial cells sit on a basement membrane, and that these epithelial cells are attached to each other by various molecules, one subgroup of which is called the cadherins. And within cadherin, a particular molecule is E-cadherin. Now, cadherins, they keep the cells attached to one another. And if tumor is going to form, for example, from this cell, what needs to happen in order for it to be able to spread locally and then to metastasize is this tumor cell needs to be able to dissociate from its neighbors. One way by which it dissociates from its neighbors is via a downregulation of E-cadherin. And so one characteristic that I've listed here in your text is downregulation of E-cadherin. Now once E-cadherin is downregulated, then this cell will attach to the laminin, which is present within the which is present in association with the basement membrane. Go back and recall from normal histology that the basement membrane is basically composed of two key molecules. The first is collagen 4. Collagen 4 makes up the vast majority of the basement membrane, and then the basement membrane also has laminin associated with it. And so the cells, once they dissociate from the neighboring cells, will actually attach to the laminin within the basement membrane. Now once they attach to the laminin within the basement membrane, the next step would be to destroy the basement membrane. And tumor cells can eventually develop the ability to produce collagenase, in particular collagenase that would destroy collagen type 4. Binding to the laminin and destruction of the basement membrane will then allow this cell to eventually come out here into the extracellular matrix. Now once the cell is within the extracellular matrix, it will attach itself to fibronectin. It'll attach itself to fibronectin within the extracellular matrix, and then it can spread locally. Eventually, it'll gain access to either the blood vessel, or it may gain access to lymphatics. And when it gains access to lymphatics, it'll spread to lymph node, and if it gains access to blood vessel, it will spread to distant sites. And so this is sort of a little bit of a paradigm. Step number 1, downregulation of E-cadherin. Step number 2, the cells then attach to laminin. Step number 3, they destroy the basement membrane using collagenase type 4. Step number 4, they attach to fibronectin in the extracellular matrix and begin to spread locally. And then step number 5 would be to enter into the vascular or lymphatic space. And if we go back to the slide, each of these steps is listed here in sequence, and you can review this within your text as well. I've already basically explained this slide to you. Recall that one of the hallmarks, or the key hallmark, of a malignant tumor, i.e. cancer, is that it will spread to distant sites. And so it's important to know that carcinomas, they tend to spread via the lymphatics. So the place where you expect to see carcinoma would be the regional draining lymph nodes. I'll just give you one example. Take, for example, breast cancer. So when a patient develops breast cancer, one of the common sites, or one of the initial sites of spread, is into the lymphatics, and then through the lymphatics into the axillary lymph nodes. And recall that the axillary lymph nodes are the lymph nodes that drain the breast. And so one important principle to know about carcinoma, about cancer, is that carcinomas spread via lymphatics to regional nodes. General principle. Carcinoma spread via lymphatics to regional lymph nodes. To highlight this, I've placed a picture in your text, and you can clearly see what this picture basically is that of a lymph node. So I'm highlighting here the capsule of a lymph node. This area here represents the normal lymph node with these small dark blue cells, and then clearly we can see that there is some tumor here which is replacing the lymph node. And notice that the tumor has a bunch of white spaces within it, and these are glands, and this is an adenocarcinoma. And so I've only placed this here to remind you of the general principle that carcinomas tend to spread via the lymphatics into regional lymph nodes. Cancer can also spread hematogenously, and hematogenic spread is characteristic of sarcomas. Recall from the beginning of this lecture that sarcomas are a malignancy of mesenchymal tissue. So for example, an osteosarcoma is a malignant bone tumor. A chondrosarcoma is a malignant cartilage tumor. A liposarcoma is a malignant tumor of adipose tissue. So mesenchymal or connective tissues, when they're malignant, we call them sarcomas. And sarcomas tend to spread through the blood. They go into the blood vessels, and then they spread to distant sites. So that's a general principle. So principle A of this discussion, principle A, is that carcinomas go into the lymphatics and spread to the regional lymph nodes. And principle B would be that sarcomas go into the blood, and the characteristic site of spread would be the lungs. Now, there are some exceptions, and so the exceptions become high yield because they make for nice test material. There are a subset of carcinomas that like to spread into the blood. So again, they're breaking the rule. And so it's important to be familiar with these exceptions because, again, it makes for nice test material. So one exception is renal cell carcinoma. And renal cell carcinoma, it's one of the characteristics of renal cell carcinoma is that it likes to invade into the renal vein, and when it invades into the renal vein, it can present with distant metastases. And it's not uncommon for a patient with renal cell carcinoma to present with distant metastases. Another carcinoma that likes to go into, that likes to spread hematogenously is hepatocellular carcinoma. This likes to invade the hepatic vein and then can spread to distant sites. A third carcinoma that likes to spread hematogenously is follicular carcinoma of the thyroid. And the fourth is choriocarcinoma. And choriocarcinoma is really easy to remember because what is choriocarcinoma? Choriocarcinoma is a malignancy of placental tissue, in particular the cells that line the villi of the placenta. And those cells are called trophoblasts. And so choriocarcinoma is a malignancy of trophoblasts. And guess what trophoblasts are designed to do by their nature? They're designed to find a blood vessel and invade into blood vessel. In fact, that's the job of the placenta. And so choriocarcinoma, I don't think it's too hard to remember that it's going to go into the blood and it's going to spread hematogenously because that's sort of what those cells are programmed to do to begin with. Now, a third way by which cancer can spread is by seeding body cavities, and that's characteristic of ovarian carcinoma. Ovarian carcinoma has the propensity to seed body cavities. It often involves the omentum of the abdomen, and so a classic picture that can arise is something like this, where we can clearly see that we're in the abdomen. This is a loop of bowel, and this is cancer that has completely replaced the omentum. Were we to actually cut through this would be very thick, and when you cut through this with a knife, it sort of has the consistency of cake. And so another term to describe this phenomena is called omental caking, and that is an important term to be familiar with, and I've placed it in your text as well. So that concludes this section on tumor progression.